Hello, my name is Deepa Dalal, and I'm at the Desert Foot Conference in Phoenix, Arizona. I just heard a very interesting talk by Dr. Bromley, who's here with me today. Thank you for the talk, Dr. Bromley, and for allowing us to interview you.
My pleasure.
So I had a couple of questions that came up. You talked about the SEEP classification. So the SEEP classification is about for venous insufficiency, is that correct?
Correct.
So can you tell us a little bit about how you utilize this in order to treat your patients, and at what stage you would start with pneumatic therapy for them?
So I think that the SEEP classification is really for us as providers to accurately document in the chart the findings in a way that we can get the modalities that we'd like to have covered by their carrier. So we're going to classify, we're going to have that in the notes, and then also do the measurements on the different parts of the leg so that we can go ahead and justify the need for either pneumatic compression or the graduated wrap systems that are covered by the carrier. So it also helps us as we do the classification to educate the patient as to where they are and the severity of their disease, and then also the measurements help us monitor how effective we are and whether or not the patient is actually wearing the device or using the pneumatic compression, and we let them know that, so that helps with compliance.
Okay. Excellent. So since there's many team members involved, you typically use like a multidisciplinary approach? Do you have manual therapy for the patients as well? Or what's kind of your approach in getting other team members involved in this?
So, great question. The team members that are going to be involved for us is obviously there's a relationship with the primary care physician for most of these patients. So the letters that will go from each consult to the primary care physician indicates what we're treating, what the diagnosis is, and what the measurements were, and what we're going to be doing. So the primary care physician or nurse practitioner or clinic that they're going to is well aware of what we're doing. I also think that as podiatrists in some practices like mine, there are a number of other providers. So being able to make sure everybody's on board, that they're all using the same treatment, and we know what we're going to do for each patient. But bringing everybody in addition, if the patient has a vascular surgeon, if they've had a PAD, or if we've sent them out for a duplex scan, we're typically using our referrals to primary care, communication, vascular, endocrinology. There are very few things that I like about EMR because of how difficult it is to use, but being able to click off the box and send these letters and measurements and notes out to our team members is very, very important to make sure we're all on the same page.
Now, you mentioned Duplex Ultrasound in your presentation as well, and you talked about how important it is to have that prior to a patient getting any kind of pneumatic therapy. When did you start using this, and how often are you ordering them on the patients? Do you order them every few weeks or anything like that, since they're continuing to get that therapy?
Again, another good question. So for me, the education process for me as an educator, it never stops. And listening and going to the vascular meetings and hearing my vascular colleagues talk about venous disease and arterial disease has just continued to help me be better educated, and then again share that education with my colleagues. So on the DVT side, as we talked about in the lecture, DVT is very, very common, and 40% of them are asymptomatic. So any of the patients that I'm going to be referring for pneumatic compression are going to have a duplex scan to rule out DVT prior to starting. Once we've started, unless they have a pain or out of proportion or something happens, we typically don't reorder it once we get the baseline, and we continue to treat. Our protocol for pneumatic compression is twice a day, and then we also use some sort of a garment, because you can't use pneumatic compression without putting something on the leg during the day to prevent it from pooling during the day. But we don't typically have to repeat. If I have a patient who is post-surgical, they presented to the office and we were worried about DVT, those patients we will do duplex scan and then follow up at 4 to 6 weeks and repeat as well during the treatment with the medication.
Okay. Excellent. I guess I just have one more question for you. As a young practitioner. I'm in my second year of residency and probably going to be working in a few years. Do you have any advice on how to appropriately identify venous insufficiency and when and how to start treating that aspect of podiatry?
Another great question. I think that what we use in our practice that hopefully you'll use in yours is that we have a patient questionnaire. So all of the new patients that come to the practice, with the exception of children, will have the typical documentation. So they're filling out, why they're here, past medical history, all the things that are important, medication, supplements, allergy, etc. There is a questionnaire that addresses the vascular disease. So there are a set of questions that refer to arterial symptoms that may present, and then there is a set of questions that refer to the venous side. And those particular questions are going to remind us as providers during that first visit to ask those questions, because somebody may come in and their chief complaint may be heel pain or maybe ingrown toenail. That's why they're there. That's their chief complaint. But by using the questionnaire on the arterial and the venous side, that prompts us to take that extra step to say, listen, Mrs. Jones or Mr. Smith, we're going to take care of your heel pain or ingrown toenail, but I'd like to talk to you a little bit about your symptoms that you reported. I'd like to take some measurements. Maybe we'll order an ABI. Maybe we'll talk about some venous studies or referrals to our colleagues, and then you can address that later in that visit or maybe a subsequent visit so that you can address the entire patient. I think that's one of the successes that you can have as a new provider, is not just pigeonhole the patient coming in for just ingrown toenail. The patient's coming in, you're looking at them, their whole body, their medications, their allergies, what they're being treated for systemically, and then looking at the whole lower extremity, not just the heel pain, not just the ingrown toenail. Look at the whole patient. There are biomechanical things that we'll look at. We do orthotics really well, and then that patient's going to walk away and go, oh my God, doctor did a great job. They not only took care of my ingrown toenail, but they gave me the most thorough exam I had. They really care about all these other things. They were looking for things. And then they're going to refer their family members and their friends. They're going to keep coming back to you. And that's what's going to build a thriving, really sophisticated practice that you'll be very successful with.
Awesome. That's really great advice. Thank you so much. Thank you, Dr. Bromley, again for the interview today. This is, again, Deepal Dalal at Desert Foot Conference. And please keep in touch for more segments to come.